It's my pleasure to introduce Dr. Willie Talbert this, I guess, morning, technically still, no, afternoon now. Willie is from Baton Rouge, Louisiana, did undergraduate at LSU and studied biology, and then stayed at LSU for medical school. We were fortunate enough to steal him up north for residency. And the next year, Dr. Talbert has taken on a primarily outpatient physician role just outside of Indianapolis, Indiana, so we will certainly miss Willie. Willie's going to talk about healthcare disparities, something that's certainly on everyone's top of everyone's attention lately. So thank you, Willie. Look forward to your talk.
Hi, everyone. Thanks for coming. Today we're going to be talking about African American health disparities. And this is kind of a continuation of Joel's talk from last week, and in part a preview of Dr. Marcellin's grand rounds this Friday. So before we discuss health disparities in the African American community, we need to define what a healthcare disparity is. Health disparities are differences and or gaps in the quality of health and healthcare across racial, ethnic, and socioeconomic groups. Importantly, disparities can exist across other dimensions, including gender, sexual orientation, age, disability status, socioeconomic status, and geographic location. I encourage you to educate yourself on all of these areas, but today we will be focusing on the specific disparities faced by the African American community. Race and ethnicity are extremely salient factors in health inequity, and therefore solutions need to take into account the social, political, and the historical context of race in this country. Black Americans have a unique story of adversity due to racism and prejudice. We will explore this history as we explore health disparities today. The structural issues defining racism in our country have been a part of its fabric since its beginnings. This image by Dr. Seeley Jefferson and colleagues lays out that 86% of the African American experience in this country was under legally sanctioned oppression. As a compromise at the 1787 Constitutional Convention, enslaved Black people were denied all human rights and counted for the purposes of determining state representation in Congress as only 3/5 of a person. Despite the emancipation of enslaved persons and the American Civil War, new Black codes restricted the freedoms of freed Black people and forced them to work for little or no wages. The Civil Rights Act of 1866 gave Black people the same legal rights as white people with regard to property, labor, and contracts, but not the right to vote or hold political office. Unfortunately, even the limited rights in the United States in 1866 were sabotaged by white supremacists, catalyzing the rise of the KKK and ushering in the era of Jim Crow laws, epitomizing structural racism and institutionalizing disadvantages for Black people under the guise of separate but equal. These actions of segregation had devastating poverty-concentrating effects, including the denial of economic and educational opportunities. The other 14% of the Black experience in the country has been in a free-ish state following the 1964 Civil Rights Act that was filled with impacts of structural racism, which means that, as Dr. Perry puts it, 100% of the U.S. Black experience has been a struggle for humanity and equality. Dr. Cameron Jones names racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks. That's what we call race. That unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. This has a significant impact on how African Americans move through life and experience health. Racial identity is a fluid concept defined in part by societal ideologies and structures that either facilitate or constrain opportunities. For much of U.S. history, stark and overt inequalities led to an oversimplified either-or dichotomy with regard to racial ideologies. African Americans as a group have long been considered a homogeneous racial and ethnic group defined by common descent, Africa as a homeland, a distinctive history, slavery in particular, and a broad sense of cultural symbols, from language to expressive culture. This oversimplification has always been problematic. However, increasing heterogeneity within the U.S. Black population, most notably through immigration, interracial births, and an expanding middle class, has laid bare the inaccuracies and limitations of those shorthand notions of Blackness in the 21st century. When we discuss the Black community, we have to be aware of the differences in experiences based on one's country of origin. We must consider African Americans descended from American slaves, African Americans descended from slaves in other countries, and African Americans immigrated from Africa. More than 1/10 of Black people in the United States are first and second generation immigrants from Africa or the Caribbean and come to the US with higher levels of human capital. Self-identified mixed race Black people also make up 8% of the total US Black population. In general, Black immigrants have lower amounts of chronic disease than Black people descended from American slaves. However, immigrants also experience the double burden of assimilating into a new culture and experiencing the unique racism in America. Merging these groups leads to inaccurate conclusions from health data. More nuance in both research and the treatment of Black patients is needed. With that background in history, let's discuss disparities further. The emergence of greater awareness and focus on health disparities has its genesis in the 1985 landmark report of the Secretary's Task Force on Black and Minority Health, issued by then U.S. Health and Human Services Secretary Margaret Heckler. The poor health status, poor outcomes, and constricted access to medical care for more than 300 years, which was anecdotally well known by many African Americans, gained greater awareness with the Heckler Report. The report objectively detailed the wide disparity in the excess burden of death and illness experienced by Blacks and other minority Americans as compared to Caucasian Americans. It also found that such disparities had been in existence for as long as federal health statistics were routinely collected. The report further emphasized the fact that 6 medical conditions between Black and white people accounted for 86% of excess Black mortality, and the fact that close to 45% of deaths up to the age of 70 in the Black population would have been avoidable if better evaluation, detection, and treatment had been available. Those 6 conditions were heart disease and stroke, which represented 14.4%, homicide and accidents, which represented 35.1%, cancer, which represented 3.8%, infant mortality, which represented 26.9%, cirrhosis, which represented 4.9%, and diabetes, which represented 1%. Let's start with disparities in cancer. African Americans as a group have the highest death rate and shortest survival of any racial/ethnic group for most cancers. African American men also have the highest cancer incidence. Cancer death rates in Black men are twice as high as in Asians and Pacific Islanders, who have the lowest rates. Prostate cancer death rates in Black men are more than double those of every other racial/ethnic group. Black women are also 40% more likely to die of breast cancer than white women and are twice as likely to die if they're over 50. Even more importantly, about a third of African American women reported experiencing racial discrimination at a health provider visit. Since 1990, the overall cancer death rate has declined faster in Black people than white people among both men and women, largely driven by more rapid declines in the numbers of cancers of the lung, colorectal, and prostate. However, racial disparities in mortality from cancers potentially affected by screening and treatment increased over most of the interval since 1975. The black lines in this chart represent the Black-white mortality rate ratio. Notice that the lines are increasing or stable in most of the charts, specifically the colorectal charts, the prostate cancer charts, and the breast cancer charts, which represents stable disparity or increasing disparity. The 5-year overall relative survival of all cancers has remained lower in Black people compared to white people. Disparities in lung cancer mortality have been explained by a number of factors. Black people are more likely to present at a more advanced stage than white people. Thus, Black patients are less likely to have the option of surgical resection, which may contribute to the lower 5 years of mortality. 5-year survival, sorry. Black people are also less likely to be recommended for lung cancer surgery and more likely to refuse surgery if recommended. The relative 5-year survival for female breast cancers was 78% among Black women and 90% among white women. The difference in breast cancer mortality may be due to more advanced stage of diagnosis for Black women. This later stage of diagnosis among Black women has been attributed to lower frequency of mammograms, greater intervals of time between mammograms, and less consistent follow-up of suspicious mammogram results. Even so, across all stages of diagnosis, Black women have poorer survival than white women. In fact, if you look at the charts in these slides, Black people have less survival across most stages of most cancer, specifically breast, colon, lung, and stomach cancers. One other source of disparities is infant and maternal mortality. The time of birth has been described as the most dangerous time in the lives of both the African American mother and the African American infant. This bears out in the data. The National Center for Health Statistics report that among the 5 racial and ethnic groups measured in the National Vital Statistics Survey in 2014, African American women had the highest percentage of preterm singleton births at 11.1%, while Asian or Pacific Islander women had the lowest at 6.8%. Infants born to African American mothers also experienced the highest rates of infant mortality, at 11.1 infant deaths per 1,000 births. And infants born to Asian or Pacific Islander mothers experienced the lowest rates at 3.9 infant deaths per 1,000 births. Infants born to white mothers had a mortality rate of 5.06 per 1,000 live births, and the overall rate, as you can see, was 5.96 per 1,000 births. The CDC's analysis of national data on pregnancy-related mortality from 2007 to 2016 found that Black women had a higher pregnancy-related mortality ratio than all other racial/ethnic populations. This was 3 times higher than the pregnancy-related mortality ratio for white women, and the gap widened among older age groups. Cardiomyopathy, thrombotic pulmonary embolism, and hypertensive disorders of pregnancy contributed to the excess and pregnancy-related deaths among Black women compared to white women. For African Americans, the social determinants of health, that is, income level, education, and socioeconomic status, are not protective factors, as they are for white Americans when it comes to maternal and infant mortality. The pregnancy-related mortality ratio for Black women with at least a college degree was 5.2 times higher than that of their white counterparts. Racism is a part of being Black in the United States, and it compromises the health of African American women and their infants. African Americans are also 32% more likely than white people to die prematurely from heart disease, and African American men are twice as likely as white people to die prematurely from stroke. Despite this increased risk of cardiovascular death, one study found that African Americans were less likely to be referred for cardiac catheterization. This persisted even after adjustment for symptoms, physician estimates of the probability of coronary disease, and clinical characteristics. A deep dive into the data revealed that Black women were the only patients who were significantly less likely to be referred for cardiac catheterization than white men, who serve as the reference category. This is direct evidence of the role that physician bias, racism, and prejudice play in the healthcare provided. These trends continue in the categories of homicides and accidents as well. Black people were victims of an estimated 805,000 non-fatal violent crimes and of about 8,000 homicides in 2005. While Black people accounted for 13% of the U.S. population in 2005, they were victims in 15% of all non-fatal violent crimes and nearly half of all homicides. There's a very significant lifelong inequity in exposure to violence for Black people versus white people. Young Black males are 4 times more likely to die from a gunshot than their white peers. Again, this is a reflection of concentrated poverty, lack of investment in education, and a lack of job opportunities. African Americans are also disproportionately in prison. Those in prison experience higher rates of chronic health problems, substance use, and mental illness than the general population. These disparities were also present during the COVID-19 pandemic. The age-adjusted death rate of Black Americans is 2 times that of white people in the United States. A recent study from the Washington Post reported that 1 in 3 Black Americans know someone who has died from COVID-19. This includes me personally. These inequities have persisted in vaccine distribution as well. So what's behind all these healthcare disparities? Like many aspects of public health, the root cause of health disparities are complex. Health is influenced by so many factors that it can be difficult to pinpoint just why a gap between 2 groups is so wide. That said, disparities are often the result of health inequities. That is, differences in how resources are distributed among different groups. These resources could be tangible, like in the case of physical parks where kids can exercise safely, or intangible opportunities such as being able to see a doctor when ill. Disparities often have multiple root causes, but there are a few major inequities in the United States that are known to contribute to health gaps between groups. Let's explore some factors that specifically affect Black people, starting with the historic mistreatment of Black people by the medical community. In 1932, the Public Health Service, working with the Tuskegee Institute, began a study to record the natural history of syphilis in Alabama. It was called the Tuskegee Study of Untreated Syphilis in the Negro Male. The study initially involved 600 Black men, 399 with syphilis, and 201 who did not have the disease. The study was conducted without the benefit of patients' informed consent. In fact, researchers told the men that they were being treated for, quote, bad blood, which was a local term that was used to describe several conditions, including syphilis, anemia, and fatigue. In truth, they did not receive the proper treatment needed to cure their illness. Even when penicillin became the drug of choice in 1947, the researchers didn't offer it to the patients in the study. Although originally projected to last for 6 months, the study actually went on for 40 years. It eventually ended in 1972 amid public outcry. The ethical concerns include the following. The true purpose behind the study was never explained to participants. Those diagnosed with syphilis were never told of their diagnosis, and treatment was withheld. Racism was also clearly involved. The researchers felt that African Americans were particularly susceptible to venereal disease because of their race and assumed they weren't interested in treatment. They even referred to the, quote, rather low intelligence of the African American population. The disclosure of the experiment in 1972 has been correlated with increases in medical mistrust and decreases in physician interactions for older Black men. The Tuskegee study became a symbol of their mistreatment by the medical establishment, a metaphor for deceit, conspiracy, malpractice, and neglect, if not outright genocide. Another example of medical mistreatment of Black people is the story of J. Marion Sims. He is considered to be the father of modern gynecology. However, he developed his surgeries by operating on Black slaves without the use of anesthesia. Interestingly, he later opened a hospital and gave white women anesthesia during the procedures. Another concern is that the women were not able to give consent to have their bodies experimented on, as they represented a vulnerable population. The slave pictured in this illustration was a 17-year-old woman named Anarcha, who underwent 30 operations at the hands of Dr. Sims. Dr. Sims also operated on enslaved children to pry their skull bones apart, as he felt that African Americans were less intelligent because their skulls grew too quickly around their brains. This is obviously very upsetting, but even more alarming is the fact that J. Marion Sims has been celebrated by the medical community, including with the erection of several statues around the country. He has been quoted as saying, "There was never a time that I could not at any day have had a subject for operation." This illustrates just how vulnerable these women were and the depth of the abuse. Black Americans are also systematically undertreated for pain relative to white Americans. Doctors at Emory University School of Medicine in Atlanta, Georgia, conducted a retrospective analysis of the medical charts of 217 patients who had presented with long bone fractures to a single urban emergency department over 40 months. Of the total, 127 patients were Black and 90 were white. The patients had similar injuries and similar complaints of pain. Overall, 43% of the Black patients received no pain medication, whereas only 26% of white patients went untreated for pain. Another study that included almost 1 million ED encounters found that Black children with appendicitis were less likely to receive pain medication than their white counterparts. Finally, a study that assessed the beliefs of white medical students and residents among biological differences between Black people and white people found that many of those students held false beliefs. 58% of the students believed that Black people had thicker skin than white people. 20% believed that Black people had less sensitive nerve endings than white people. These beliefs may be part of the reason why physicians give Black people less treatment for pain. In total, about 50% of the students surveyed held at least one false belief. Importantly, these studies highlight how Black people get treated differently in the healthcare system. African Americans are aware of these differences, and this is contributing to medical distrust. Another factor related to healthcare disparities in African Americans is rampant income inequality and economic disadvantage. Income is a major factor in a family's ability to access healthcare, which can make up a significant share of household spending in terms of insurance premium costs and out-of-pocket costs. Black families consistently have the lowest incomes, with the median Black family making around $46,000 compared to the $76,000 median income of white families. The median white family also has 41 times more wealth than the median Black family. This income inequality persists even in those with college and postgraduate degrees. Poverty is a prime predictor for lacking basic human essentials, including adequate clean water, nutrition, healthcare, education, clothing, and shelter. African Americans are the poorest ethnic group in the United States, and this contributes to increased morbidity and mortality. Acknowledging the lack of Black doctors is important to understanding health disparities in African Americans as well. African Americans make up 13% of the American population, but only about 4% of practicing physicians. African American women represent only 2% of practicing physicians. This graph shows the low number of African American matriculants to medical school and how this has been relatively stable since 1978. So why should we care that we don't have enough Black doctors? Well, the data shows that this lack of Black providers is leading to worse outcomes for African American patients. This chart is from a study that examined 1.8 million hospital births in the state of Florida between 1992 and 2015. The results suggest that newborn physician racial concordance, so that means the physician and the patient are of the same race, is associated with a significant improvement in mortality for Black infants. Under the care of Black physicians, there was a 58% reduction in the infant mortality rate of Black babies. The same study found no difference in white infant mortality when cared for by a Black or a white physician. Analysis of U.S. Census data has found that the average white person in metropolitan America lives in a neighborhood that is over 70% white, whereas a typical African American lives in a neighborhood that is only about 30% white. And that's not much different since 1940. Low-income African Americans are also more likely to live in a low-income neighborhood compared to low-income Caucasians. The quality of housing affects health, and African Americans live in some of the country's lowest quality housing. Location is also a health determinant, and African Americans live in the poorest neighborhoods with the highest rates of homicides. Transportation is often a problem in poor communities, presenting obstacles to accessing healthcare services, especially preventative care until emergencies arise. Access to healthy food is also a frequent problem in poor African American communities, and Black neighborhoods have significantly fewer supermarkets than white ones. Several studies also document that the food that is available in poor Black neighborhoods is less fresh and of lower quality. Racial segregation is important to talk about because it makes it easier to withhold resources from minority communities through a host of negative policies, including over-policing, underinvestment, and devaluation. Research has shown that physician supply is inversely related to the concentration of Blacks and Hispanics in the health service area, even after adjusting for community income level. Omaha hasn't been immune from this racial segregation. North Omaha remains the place where most African Americans in Omaha live. The term redlining refers to when mortgage lenders refuse to give loans based on race or geographic location. Using red ink, lenders outlined on paper maps the parts of the city that were considered at high risk of default, as well as more desirable neighborhoods for approving a loan. Riskier neighborhoods were predominantly Black and Latino. This practice greatly contributed to the racial segregation seen today. Many of the issues we've explored today so far can be explained by structural racism. So racism operates at multiple levels, ranging from the individual to the structural. The metaphor of an iceberg is useful for describing the levels at which racism operates. The tip of the iceberg represents acts of racism, such as cross-burnings that are easily seen and individually mediated. The portion of the iceberg that lies below the water represents structural racism. It is more dangerous and harder to eliminate. Policies and interventions that change the iceberg's tip may do little to change its base, resulting in structural inequalities that remain intact, though are less detectable. Structural racism is found in the way that Black people are portrayed in media. Structural racism is found in the fact that Black people are massively incarcerated, the lack of political representation for Black people is systemic racism, the occupational, residential, and school segregation, and mortgage redlining all represent acts of structural racism, as we discussed. This structural racism leads to differential access to the goods, services, and opportunities of society by race. And that determines societal values and power hierarchies and underlies persistent health disparities in the United States. Reviews consistently find that persons who self-report exposures to racism have greater risk for mental and physical ailments. These associations are seen among many racial/ethnic minority populations, including African Americans. Structural forms of racism and their relationship to health inequities remain under study. A comprehensive research program on racism and health must account for the key ways that historical factors influence present outcomes. The racist actions and inequities experienced by one generation may be felt across subsequent generations. This may explain seemingly inexplicable disadvantages across conditions, subpopulations, and time. So this is a slide showing the complex interaction between racism and health as explained by the weathering theory. This theory proposes that the constant stress of racism can lead to premature biological aging and worse health outcomes. Systemic inequalities and structural influences such as resource allocations, living and working conditions, community resources, and the dominant cultural systems all combine to influence the biological environment. These stressors lead to physiologic adaptation and or disruption. And the concept of allostatic load suggests one biological mechanism for this weathering. This is the idea that overexposure to stress hormones can cause wear and tear on body systems. Biomedical and social science research supports the notion that chronic exposure to stressors contributes to the cumulative dysregulation of biological systems, shaping disparities in health and aging. These effects accumulate over time and across generations and leads to the deterioration in health as a result of racism. This figure summarizes what we've been discussing. It illustrates how racial bias can create health disparities via 3 paths. The discrimination path, which is at the top, concerns how everyday experiences of racial bias can directly affect the health of African Americans. Being the target of persistent discrimination creates stress that erodes overall health and increases susceptibility to disease and certain medical conditions, which ultimately leads to racial disparities in health. The physician decision path demonstrates the fairly direct effect of clinician implicit bias on medical judgments and treatment decisions concerning Black patients. The physician-patient relationship path is the more indirect effect of provider implicit bias on clinical communication, which then reduces patients' trust and acceptance of treatment. These all lead to healthcare disparities. Okay, so what do we do about these disparities? Before we talk about some solutions, I do want to acknowledge that I imagine many of you are uncomfortable with this discussion. Please recognize that when we discuss structural racism, we're talking about systems and policies, not your individual actions. We have to commit to questioning these systems and policies in the same way that we question all other things in medicine. So listen with intention and think of how these solutions and the data presented so far apply to your patients. I think it's natural for any discussion of health disparities to lead to a discussion of equality. That is, equality in the sense that everyone is treated the same and are given the same resources. This sounds like an ideal solution to health disparities in all aspects of racism and inequalities. However, we should really actually be striving for health equity, which means striving for the highest possible standard of health for all people and giving special attention to the needs of those at greatest risk of poor health based on social conditions. The picture featured in the slide is a representation of this. If you don't consider the personal factors of each person, equality still isn't adequate. Even if they all receive the same bike, they all wouldn't be able to use it. However, if you do take their differences into account, they can all use the bike as a mode of transportation comfortably. Practically, this looks like some people receiving assistance that others don't. I think in our individualistic culture, this is a hard pill to swallow, but it is appropriate when you consider the history of certain groups in the United States, especially Black Americans. So first, some physician-focused approaches. The elimination of healthcare disparities is difficult and multifaceted challenge with no single solution, but there are some things that we can all do. We must do the important work of acknowledging and dismantling racism in our systems, from maltreatment of Black patients to prejudice against Black colleagues, Black students, and Black trainees in research grants, admissions, promotions, rewards, compensation, and representation. Healthcare institutions and organizations need a culture shift to make anti-racism foundational to our core values and operations. The ways in which racism contributes to health need to be taught to trainees. Being an anti-racist means actively working against racism. In medicine, this looks like evaluating curricula, practices, training models, behaviors, and actions through a lens of anti-racism. We must also individualize patients. Even when physicians are aware of racial disparities in healthcare, they may not recognize how their personal beliefs and actions contribute to these disparities. Physicians should individualize patients. That is, to see each patient as a unique individual rather than mainly a representative of some racial or social group. Effective patient-centered communication can achieve this. Instead of ignoring race, this approach recognizes racial differences in an exchange between two co-equal individuals. This helps to establish positive interpersonal relationships between physicians and patients. You should also be aware of this stereotype threat, in which minorities fear that they will be judged against a stereotype, and any misstep will confirm those stereotypes. This affects how Black people communicate and interact. We also need to increase the number of Black physicians, and to do this, we have to use a multi-pronged approach. Some ideas are that we must make physician diversity a priority. We need to de-emphasize MCAT scores in the medical school admission process. It doesn't predict which students will do well reliably anyway. We should also eliminate exam and interview fees when possible, as Black students have less access to wealth and income, as we've already discussed. We need more pipeline programs that focus on recruiting and supporting underrepresented minorities. Additionally, medical schools, residency programs, and hospitals need to provide mental health support for Black trainees, given the disproportionate maltreatment by patients and colleagues. We should also incentivize mentoring of Black trainees and young Black physicians, as Black faculty in academic medicine often disproportionately serve as mentors without having mentors themselves. More of this is coming later in this week during grand rounds with Dr. Marcellin. So what does anti-racism look like in action? Organizations need to articulate specific, bold, meaningful goals that relate to actions and changes, not stances, not feelings, not generalizations. They should acknowledge the starting point and what progress looks like. For example, here are the ways in which racism and racial inequity exist within our walls. Here is what we must accomplish, and here are the steps to ensure we get there. Language should be clear. The goal is to address racism, not merely culture, not respect. Organizations also need to contribute to the knowledge base. Even with the best of intentions, all organizations will struggle to succeed in abolishing racism without an industry-wide investment in formal examination of anti-racist efforts. Research should not focus on gathering further evidence of already well-documented inequities, but should push to finding effective interventions. Organizations must also be thorough in scrubbing out inequity from every place, every process, and every practice. Racism is in a very physical environment of healthcare settings. It's in the artwork, in textbooks, in learning modules, in the equipment such as resuscitation mannequins. It is present in clinical processes, including race-based diagnostic and treatment algorithms. It is signaled through decision-making processes, resource allocation, awarding of honors, types of and participation in social gatherings. Racism penetrates all organizational endeavors, so the response to it needs to be just as broad and all-inclusive. Organizations should also transform the workforce, including leadership. Racial equity in the workforce is both a mediator and a moderator of health equity. A flourishing, diverse workforce provides health benefits to a diverse patient population and strengthens the equity of the entire organization. Failing to bring equity to positions of power reflects hypocrisy and insincerity and will inhibit sustained anti-racist work. Academic medical centers should also adopt a stop the line for racism culture, in which patients, students, trainees, staff, and faculty alike are empowered to identify and work towards ending racist behavior, policies, and practices. This is modeled after the Toyota's company's approach to safety concerns that provides a safe environment for anyone to speak out if a problem is detected. Racism should be approached in the same way. Equity efforts require strong, high-level, and sustained financial investment. Those academic medical centers that are committed to being anti-racist must critically examine and reform the education and engagement of their students, trainees, faculty, staff, and community, as well as institutional policies and practices. Funding and evaluation are central to the sustainability and continuous improvement of these efforts. Today, racism often occurs unintentionally, fueled primarily by unconscious prejudice and stereotypes. Many people are unaware of their biases and therefore unlikely to change. However, for those that aspire to be non-prejudiced, it is possible to reduce biases when you are made aware of them. Exercises that prompt us to compare what we would do and what we should do in a variety of circumstances, such as the implicit association test, can reveal unconscious prejudice and believed stereotypes. This allows for self-discovery within a non-threatening, private context and appeals to a provider's desire to provide the best possible care to all patients. Psychological research has also shown that white people often feel anxious when interacting with Black people because of a lack of positive experiences with interracial encounters, which leads them to avoid such interactions. In the context of a clinical encounter, this may translate into white providers engaging in avoidance behaviors and spending less time with non-white patients, leading to poor patient-provider relationships. Non-white patients who may be particularly vigilant for signs of prejudice or rejection may interpret signs of anxiety displayed by white providers as reflecting negative attitudes. The most successful way to decrease this anxiety and increase provider confidence is through increased interactions with members of other groups. Enhancing provider empathy is another strategy for increasing the effectiveness of patient-provider interactions. Although the development of empathy is a general aspect of medical training, providers may not recognize inherent obstacles to empathizing with patients from a different racial or ethnic group. People tend to have less empathy for others perceived as dissimilar, which typically results in low rapport. Adopting the perspective of another person has been shown to decrease bias towards stigmatized groups. Many studies have documented the positive effect of provider empathy on patients, including increased patient satisfaction, increased patient adherence, perceptions of control, less emotional distress, and better outcomes. A practical step to take is to spend a moment in each encounter, imagining yourself living in the shoes of the patient, feeling what he or she feels. Partnership building can improve the effectiveness of patient-provider interactions by reframing the interaction as one between collaborating equals, rather than between one high-status person, the doctor, and one low-status person, the patient. In the United States, race, ethnicity, and sex represent automatically activated categories that form the basis of in-group, out-group differentiation. In general, people retain more information and remember more positive information and are more forgiving of behaviors of the in-group members compared to out-group members. Creating a partnership which produces a common ground identity reduces conscious and unconscious racial biases among interracial interactions. Practically, this looks like partnership building. Partnership building looks like finding common ground in regards to the nature of the medical problem, the goals of treatment, and the roles of the doctor and the patient. This approach can help build trust between physicians and Black patients. Now let's shift gears to solutions to racism at the societal level. While individual interventions are important, the systemic nature of racism as a cause of health disparities must be counteracted by equally systemic measures. Through social programs, economic investment, criminal system reform, decreased segregation in positions of institutional power, more inclusive research, and appropriate funding of public agencies, healthcare institutions, and historically Black colleges and universities. This figure specifically mentions COVID-19, but the solutions are generalizable. Community organizations have tremendous potential to eliminate healthcare disparities through recruitment of multicultural workforces, promoting accessibility to health resources, combating segregation of services, and integrating culturally competent care resources into the mainstream healthcare system. Businesses should also contribute to eradicating disparities by ensuring minority employees and their families receive access to equitable care. State and local governments must also leverage their administrative, regulatory, and legislative capacities for reduction of healthcare disparities. This can be accomplished by more broadly disseminating legal and regulatory standards for cultural competence, public health efforts, data collecting, and monitoring of changes in healthcare disparities, promoting relevant research, and enforcing civil rights laws. We must demand these things from our elected representatives. The current picture is clear. The greatest health disparity between the total U.S. population and any ethnic group is found in African Americans. I hope that this presentation has convinced you that we all have to be better. Our Black patients deserve to be treated just as all of our other patients, and we should all commit to calling out racism whenever we see it and fighting to overcome our own biases. So thank you. I want to specifically thank my wife, who has been with me throughout this long medical training process, and then also Dr. Marcellin, who was a great help in helping me coming up with this presentation. And that's all. Thank you for your attention. Questions, comments?
I thought that was an outstanding presentation, and I think you're amazingly brave. I think you've been in the minority your whole time here at UNMC, and you've been a leader and somebody that everyone wants to hang out with every step of the way. And if we could clone Willie, I think we all would. And so thanks for talking about a tough subject and keeping us all in the place where we need to grow.
Thank you. Dr. Marcella.
Excellent job. I'm really proud of you, Willie.
Thank you.
This was a great discussion, and appreciate the props for the talk that I'm going to be doing on Friday, which is not going to repeat anything that Willie said. So one thing, I don't have a question. I just have more of a comment that I think is important to state, and I'm hoping that I'm talking loud enough that the folks on Zoom can hear. When we're having this kind of conversation, sometimes it's important for us to spend time in the beginning talking about the history and what that means. And when I speak about this kind of thing, I always get a question of, well, why talk about the history? It's in the past. It's important to contextualize what the past actually means. I think Willie did a great job of talking about how the past connects to the present, and in some ways, as meta as it might seem, the past is the present, because all of the things that we were seeing, so yes, the institution of slavery is gone, it's no longer there, but with that second slide that kind of showed some of the issues and oppression that people are still experiencing today, it's something that we really need to consider what people are seeing right now. When you think about, for example, COVID-19 vaccinations, right? And a lot of the discussion about COVID and vaccine allocation is the Black community doesn't trust, the Black community doesn't want to take the vaccines. The reality is there's a whole ton of folks who want the vaccine. I talk to them all the time, right? And they don't have access to the vaccines. The vaccines are not coming into their community. They don't have transportation to make it to the vaccine sites. And yes, Tuskegee is a part of consideration, but it is not the only thing that people think about when they're making decisions about health today. And I could share I may have already shared with y'all the story about my son and when he broke his arm, but like these things are happening today to the Black folks in our community. And so I just hope that everyone who's listening to Willie talking today, and I really take from this that our patients, we really need to be more curious about what is going on with each of our patients and what their individual experiences might be that lead them to where they are, and come from a place of empathy and come from a place of appreciation and acknowledgement. And if we do that, I think individually as physicians, we all have an opportunity to make people's lives better and to change the end part of that second slide that showed that people are under oppression. Maybe we can get to a place where it stops in 21 and people can feel actually free. Thank you.
So well said. Anything else? All right, thanks, Josh.